A patient walks into a clinic. Their X-ray shows severe bone spurs, narrow discs, and advanced osteoarthritis across the lumbar spine. Yet as the spine is flexing and bearing weight, they report absolutely zero back pain. Another patient presents with a pristine MRI. There is no visible nerve compression and no disc herniation, but they are entirely disabled by a deep, aching pain radiating into their glutes and thighs. Low back pain affects over 60% of people at some point in their lives. Of those cases, up to 40% are driven specifically by facet joint pain originating from the small, stabilizing joints located between each vertebra. Despite this high prevalence, the condition is frequently misdiagnosed. The lumbar spine is a highly complex anatomical network, and facet joint pain lacks definitive biological markers. Traditional physical exams offer little clinical certainty. Maneuvers involving localized palpation or Kemp's test, which requires backward flexion and rotation of the spine, have poor predictive value for isolating the facet joints as the true source of pain. This leads to a pervasive clinical error, relying on static structural imaging. Scans like MRIs and CTs consistently fail to correlate with a patient's actual clinical symptoms. An MRI is highly sensitive and will readily identify subchondral bone marrow edema or joint sclerosis. However, it cannot definitively prove that these anatomical abnormalities are actively generating nociceptive or pain-inducing signals. To effectively manage this condition, clinicians must abandon purely structural assumptions. The focus must shift toward functional diagnostics and targeted nerve ablation to locate and neutralize the true pain generator. Locating the active pain generator requires a shift in perspective. Diagnostics must look past static bone deformation and instead measure metabolic activity. This is achieved using SPECT-CT imaging. Single-photon emission computed tomography combined with a CT scan functions as a metabolic map, highlighting areas of active cellular inflammation rather than old inactive bone changes. Looking at this scan, the diagnostic advantage is clear. The standard axial CT shows structural anatomy, while adjacent frames reveal locations of high metabolic turnover. Sagittal and coronal views show intense L4-L5 activity. 65% of these hotspots link to facet joint pain. This metabolic mapping directly correlates with treatment readiness. Patients with SPECT-positive scans are significantly more likely to experience pain relief from subsequent targeted nerve blocks. Even with an accurate diagnosis, the standard treatment approach is often flawed.
A common intervention is the intra-articular infiltration, where corticosteroids and anesthetics are injected directly into the facet joint space. This procedure presents severe mechanical difficulties. As seen in this cross-section of a degenerated joint, severe joint space narrowing and bone spurs physically block the needle. Because of this structural interference, intra-articular injections carry a failure rate of up to 29%. The capsule is densely packed with sensory nerve endings that fire when exposed to mechanical stress and pro-inflammatory cytokines, specifically TNF-alpha and interleukin-6. Pain signals travel through a specific conduit, the medial branch, coursing through the groove formed by the articular and transverse processes. Descending multiple vertebrae, this nerve provides both the sole sensory input to the facet joint and motor input to the stabilizing multifidus muscle. Because of this highly specific neural pathway, clinicians use diagnostic medial branch blocks as a strict gatekeeper procedure. This temporary anesthetic block must be performed before any permanent nerve ablation is considered. However, these blocks carry a significant clinical flaw. The literature shows a high false positive rate for medial branch blocks, ranging from 25 to 40%. This error is driven by fluid dynamics. Injecting too much anesthetic causes it to bleed into adjacent muscles or get absorbed by nearby blood vessels, occurring in up to 30% of cases. To mitigate this, guidelines strictly mandate using between 0.25 and 0.5 milliliters. This rigor profoundly affects both clinical outcomes and economics. Performing zero diagnostic blocks yields a 33% ablation success rate at a cost of roughly $6,000 per successful outcome. Implementing a strict dual block protocol drops the overall success rate to 22%, but pushes the cost to over $15,000 per success by aggressively screening out false positives. Medial branch blocks are not therapeutic treatments.
They are rigorous, low-volume diagnostic filters, absolutely necessary to prove the medial branch is the true pain conduit before moving to permanent ablation. Once the medial branch is confirmed as the active pain generator, the evidence-backed gold standard for treatment is radiofrequency ablation, or RFA. Continuous RFA relies on applied thermodynamics. An active electrode generates an electromagnetic field, causing ionic agitation in the surrounding tissue. This friction generates heat, which disrupts the nerve's ability to transmit pain signals through a process of protein denaturation. The success of this procedure hinges on a core geometric challenge. The thermal lesion created by the RFA probe is an ellipsoid, extending along the shaft of the needle, rather than a perfect sphere at the tip. Historical techniques frequently failed because a perpendicularly placed needle creates an oval heat lesion that entirely misses the adjacent nerve. Modern protocols mandate a strictly parallel approach, rotating the needle so the ellipsoid heat lesion perfectly engulfs a long segment of the nerve path. Looking at this lateral X-ray, achieving parallel alignment requires positioning the C-arm in a steep caudad to cephalad direction. The physical inclination is severe, reaching 40 degrees from the cranial endplate at the L5 level and increasing up to 57 degrees at the sacrum. As seen in this oblique scan, clinicians confirm this precise placement using fluoroscopy. The needles are targeted directly at the junction of the superior articular process and the transverse process, an anatomical landmark commonly referred to as the eye of the Scotty dog. However, physically touching the nerve is only half the equation. The applied temperature and time must be perfectly calibrated. Temperatures exceeding 90 degrees Celsius risk charring and vaporizing the surrounding tissue, which insulates the nerve and stops the ablation. The clinical sweet spot is maintained precisely at 80 degrees Celsius for 90 to 120 seconds. This chart shows how lesion size scales with needle gauge and heat duration. A 16-gauge needle at 90 degrees for 3 minutes yields an 11.1 millimeter lesion, whereas an 18-gauge needle at 80 degrees for 2 minutes produces a smaller 7.6 millimeter lesion. Halting the pain signal through radiofrequency ablation relies on the rigorous application of geometric orientation and applied thermodynamics. The calculated precision of targeted ablation stands in sharp contrast to the ongoing controversy surrounding invasive spine surgeries for purely mechanical low back pain. Major health organizations such as the National Institute for Health and Care Excellence, or NICE, strongly advise against procedures like spinal fusion or disc replacement when there is no clear neural compression or structural deformity present. Despite these guidelines, there is a rising trend of experimental devices designed for dynamic stabilization and facet arthroplasty, aimed specifically at treating mechanical low back pain. Looking at this Phoenix implant model, we see an attempt to mechanically replace the degenerated facet joint surfaces. In close-up, the structural fit is clear. Two metal components are inserted between the articular processes to artificially recreate the joint space. While these devices demonstrate proof-of-concept feasibility in early trials, their application for purely non-radicular mechanical pain remains highly experimental and lacks long-term clinical validation. This brings us back to the core reality of the condition. Lumbar facet disease is primarily a nociceptive and inflammatory signaling issue. It is not a structural collapse requiring mechanical fusion. The ultimate goal is to cut off the faulty electrical signaling from the inflamed joint. We are shutting down the transmission line. The optimized clinical pathway requires a total rejection of old diagnostic habits. Clinicians must discard their reliance on static structural MRIs, utilize SPECT-CT to locate active inflammation, and deploy strict low-volume medial branch blocks to isolate the exact neural target. By treating lumbar facet disease as a functional signaling problem rather than a structural mechanical failure, medicine can leverage the physics of targeted radiofrequency ablation to provide precise, evidence-backed relief for patients.